Hi, good evening. Glad to see all of you have logged in to this pulmonology forum. It's endorsed by the Indian Chest Society, and we'd give special credit to the organizing team and also, of course, to GSK for putting together this team. I've been in talks with Dr. Yogesh, and so have the other speakers. Today, we're going to be talking about COPD management, and to take us through this whole thing is Dr. Amita Nene. Could I have Dr. Amita's slide, and she'll be introducing the topic further. Okay, Dr. Amita Nene actually deserves no introduction. I mean, everybody knows her. She's the HOD of Respiratory Medicine at Bombay Hospital in Mumbai. And while she's been awarded Legend in Pulmonology by the Union Minister, I think every single pulmonologist in this country knows her and acknowledges her as a legend. She's been named among the leading Indian women pulmonologists by Respirology. She received the prestigious Young Achiever Award, has authored several chapters in over 40 scientific publications. She's been very active on the board of regents of the prestigious WABIP. She's been on the National Guideline Making Committee that made the Indian guidelines for ILD and vaccination. We also know her for her achievements, not only with the ICS, but also with the IAB, where she's done great work with bronchology in this area. So, but more than anything, I think on a personal note, Amita brings, a sense of great satisfaction to people when she acknowledges their responses. She will insist on replying to every single message that comes to her individually. And I can't think of too many people who can do that. And of course, on a completely different note, she is a very accomplished musician and dancer. And if you just look behind her in her background, you'll see these things when she's at home. Right now, she's in the hospital, continuing to work, and will take a long time to reach home. So, Amita, that is something we all admire greatly about you, your range of interests, apart from your great knowledge of pulmonology. And I'm going to hand it to you at this stage.
Thank you so much, Dr. Murli. I'm just so overwhelmed. I don't know what to say. I mean, today is the best day of my life because, one of my closest friends, who I respect so much, who I'm extremely fond of, has really showered me with the best compliments that I'd like to hear. So thank you so much. I'm really touched, and thank you once again. So with this, let's just start today's webinar. So first of all, I would really like to thank our Indian Chest Society, led by Dr. Sandeep Salvi as the president, and Dr. Rajadhar as our secretary, and the entire Indian Chest Society for taking this fantastic initiative of making sure that week after week, every Wednesday, we have a webinar that goes on, and every webinar is of great quality. And I think today is going to be one of the best webinars till date because we have the best possible faculty. We have Dr. Murli, we have Dr. Arjun Khanna, and we have a very fantastic and interesting topic, whether it's PRISM or whether it's about iOS, all the new concepts on COPD, which will make us practice better and which is going to help our patients even more. I'm so grateful to Team GSK for being our academic partners, and Dr. Yogesh has been so helpful, and he's taken a fantastic lead in making sure that everything comes across well. So before we start, I would just like to tell our audience that on your screen, you'll be able to see the pre-poll questions. So if you can just give the answers now, and at the end of the webinar, we'll ask the questions again, and let's just find out. So I'll just wait for about 5 seconds for audience to answer. Great, fine. So I think we can remove this slide and we can have Dr. Murli's slide, please. Team GSK, great. Okay, so I have the honor of introducing none other than Dr. Murli Mohan, who absolutely requires no introduction. If the entire country knows me, then I would say the entire universe knows Dr. Murli Mohan. So we all know that he is a fantastic pulmonologist, one of the greatest academicians, and he's a consultant pulmonologist, the senior one, and HOD of Internal Medicine and Pulmonology at the Mazumdar Shaw Medical Center, Bangalore. Special interest in areas of asthma, COPD, sleep medicine, and CPR. He has over 30 papers presented at various national and international conferences and several papers in international journals. He's a joint author of WHO manual on tobacco cessation, which is phenomenal. In fact, in the areas of interest, I would have put pulmonary hypertension as number one, because whenever anybody in the country has any problems with any patients of pulmonary hypertension, there's only one name written on our paper, Dr. Murli Mohan, please go to him. And I believe he's also at Narayan Rugnalay. I don't know, it's not mentioned over here. But basically, he requires absolutely just no introduction. And he also heads Nightingale's life-saving services, which has to date trained over 20,000 persons in CPR in Bangalore. So an amazing achiever, a fantastic CV to die for, and most importantly, a great human being and a great, great friend of mine. So over to you, Dr. Murli. Please enlighten us.
Thank you so much, Amita. This introduction slide, I don't know where they got it, is from roughly 15 years ago.
Even mine was, because I have like 60 publications. I think this was 10 years old, but it's okay.
Yeah, so I now have over 100 publications, and the WHO manual was printed about 15 years ago, which is why I know this is 15 years old. And we've trained over 90,000 persons in CPR in Bangalore. So
wow.
This needs some
This is
change.
Amazing, absolutely. So Team GSK needs to update, definitely.
No, I think they've taken it from the Narayan Hrudayalia website, which is outdated terribly.
Correct, absolutely, yeah. And they asked me for the CV, I didn't send any, so they had to just make up something.
Thank you so much for that kind introduction. Can we go on to the presentation, please? So today I've been asked to speak about PRISM and pre-COPD. And these are very, very important areas that have been spoken about intermittently in the last few years, but are now gaining momentum. Can we have the next slide, please? Yeah, so basically these are our disclosures. I've received an honorarium for the speaker engagement, and these slides are developed through GSK for an external, by an external expert. I have contributed to these. I have made some suggestions and changes. So I do take some of the responsibility for these slides also. And of course, I will be discussing where and when I will, present these slides. I will be giving a few of my own points of view. Next slide, please. So what are our learning objectives for today? We want to understand PRISM and pre-COPD, and I'll be spending some time on explaining what these concepts are. We'll talk about the association of PRISM with COPD, but most importantly, we would not want to know how to diagnose it, how to prevent and treat PRISM and pre-COPD. And these are very nebulous areas because we are still at a very early stage of understanding of these conditions. But this is probably one of the early seminars where you're going to hear about it. Next slide, please. So let's talk first about how one understands PRISM and pre-COPD. Next slide, please. Yeah, so what is PRISM? PRISM is defined by a reduced FEV1. So the FEV1 is reduced, but the ratio of FEV1 to FVC is preserved. That is, it's greater than 0.7 or 70%. And why is this important? Because we've always defined COPD as associated with a reduced FEV1 FVC ratio. That is a cutoff of less than 0.7. A lot of people have spoken about using a different, means that is less than the lower limit of normal. But I think most of us are used to this 70% cutoff. And we're also very unsure about what is the lower limit of normal for an Indian population. So in India, especially, we continue to use the cutoff of 0.7. And when this is associated with the reduced FEV1, it becomes PRISM. Previously, this was referred to as a gold U or a restrictive, an unspecified or a non-specific pattern. But it's important to recognize PRISM because it may progress to more severe lung conditions, including COPD. And therefore, if we are more aware of it, we can make a more accurate diagnosis. This would be essential for managing it appropriately, intervening early, and hopefully preventing the progression to more advanced disease. And one of the things we realize is that almost a third of patients within 4 to 5 years, those who have PRISM do progress to frank COPD, which is defined by the reduced FEV1 FVC ratio. So it looks like PRISM can be thought of as a transitional state to COPD. This is very similar to what was earlier called gold zero, where there was normal lung function in patients with risk for COPD. So we are moving away, and I think in the earliest gold guidelines, 2001, they said we did speak about gold zero, and in later guidelines, they moved away from it. But this is important, and I'll come back to why PRISM and the concept of pre-COPD are important. Next slide, please. So when you classify PRISM, basically you have a preserved ratio, but the spirometry is impaired. And now we can recognize two different kinds of PRISM. One is those with a restrictive abnormality and those without a restrictive abnormality. How do we define restriction? We're talking here about people with an FVC less than 80%. They may also have an FEV1 less than 80%. Naturally, when your FVC is low, your FEV1 is often low, but their ratio is preserved. And when you have an FVC of less than 80% of predicted, you know that you're dealing with a restrictive condition. Whatever the cause of the restriction, is it ILD, is it obesity, is it a chest wall restriction, as happens, for example, in ankylosing spondylitis, here the lung volumes are reduced, and here there is no evidence of airflow obstruction. On the other hand, when you don't have a restrictive abnormality, this is defined as an FEV1 FVC ratio of greater than 0.7, so preserved ratio, but the spirometry is impaired slightly differently from those with the restrictive abnormality. So you have an FEV1 which is less than 80% of predicted, but your FVC is greater than 80% of predicted. So there's no restriction. However, there is a beginning of an airflow abnormality and airflow obstruction. They haven't yet reached the cutoff of 0.7. So these patients are those who are associated with an increased risk of developing airflow obstruction. And they may indicate a very mild kind of lung disease, which has not yet reached the stage of cutoff. Because if you have a very high cutoff, you'll be over-diagnosing the condition. And yet we recognize that in PRISM, without a restrictive abnormality, you may be picking up a lot of patients. And as I mentioned earlier, almost a third of patients who within the next 4 to 5 years will develop COPD. So this is an important condition to pick up. And I used a wrong term. I said patients with these features. And I don't think these are yet patients necessarily. About 2/3 of them may still be just persons with this kind of PRISM, and therefore it would be erroneous on my part to use the term patients. Next slide, please. So this was a nice paper by Miura. It appeared about a year ago, and this took a large group of patients, over 12,000 patients, aged between 35 and 65 years. They'd undergone spirometry, and they'd had self-administered questionnaires. And this was over an 8 to 9 year period between 2007 and 2009. This was done as part of their routine health checkup. They excluded a few for various reasons, including incomplete questionnaires and pre-existing other lung disease, and came out with over 11,000 eligible participants. And when they looked at the spirometry of these patients, there was one group, about 380 to 400 patients, who very clearly had obstructive airways disease, as recognized by an FEV1 FVC ratio of less than 0.7, the cutoff that we spoke about. But in those with the larger than FEV1 FVC of greater than 0.7, they again looked at the FEV1 and FVC of less than 80% and greater than 80%, and then later subdivided them as FEV1 greater than 80% and FVC greater than 80% and FVC less than 80%. So those who had an FEV1 FVC greater than 0.7, they had preserved ratio, also had preserved FEV1 of greater than 80%. So there's no evidence of PRISM. And therefore, when they followed them up, looked at them in greater detail, there was no further progress to airflow obstruction in the longitudinal analysis. But when they looked at those with an FEV1 of less than 80% of predicted and an FVC of greater than 80% of predicted, they had about 214 patients who had the so-called non-restrictive PRISM. Next slide, please. So what is pre-COPD? So we're moving away from PRISM. Let's not confuse the two. So PRISM is defined by spirometry. We're moving on to pre-COPD. And pre-COPD represents patients with no evidence of airflow obstruction. They have an FEV1 FVC ratio of greater than 0.7, greater than the cutoff. But these are people who are at risk of progression to COPD. They have early pathological changes in their lungs, or they have an accelerated lung function decline, but they have not yet reached the cutoff value for COPD. And you'll understand that there is bound to be some degree of overlap between the pre-COPD and PRISM populations, but they're not exactly the same. So if you look at the diagram on the left, you can see on the y-axis, you have the FEV1 FVC ratio, and on the x-axis, you have the age of the patient. And you also have those who have symptoms as defined by the COPD assessment test. Okay, and we have 4 quadrants here. In the top quadrants, you have those who have a preserved ratio. And in the bottom quadrants, you have those who have the ratio of less than 0.7. So these are people who meet the criteria for COPD to some extent. And many of these patients who you can see are in the less than 50-year age group. Once they are more than 50 years, you're more likely to, diagnose COPD in them. But these are patients with a younger group. And these are often patients who meet the criteria for early COPD. So these are patients who have destruction of the smaller conducting airways. These are, as you know, those with a diameter less than 2 millimeters of mercury. And this is a very, very important stage in their progression from having normal lung function to the stage where they are called early COPD. Some of these patients, when you do their body box measurements, will have an elevated residual volume by TLC ratio. And this indicates that they have small airways obstruction leading to air trapping. So how do we actually define pre-COPD? This was first defined by Mark Merivittles and his group many years ago. And you see the reference below. Pre-COPD, they defined as the presence of emphysema of greater than 5%, and or the presence of bronchial thickening in the CT scan, and or, so any of these features, DLCO less than 80% are predicted in subjects with respiratory symptoms, and a post-bronchodilator FEV1 FVC ratio greater than 0.7. So they have PRISM, but you look at 3 different factors. You look at a CT-defined emphysema greater than 5%. You see a bronchial thickening on the CT, and that is defined in a certain way, which we shall not go into the details now. And you have a DLCO less than 80%. So any of these will tell you that the person is progressing towards COPD, and therefore they call this pre-COPD. Next slide, please. If you look at how common these conditions are, the prevalence of PRISM is estimated worldwide to be between 7 and 13%. So a fairly large population, given the overall numbers that we're looking at. There was a single Indian paper, Bansal and et al., from a single medical college in India, but I'm very glad they came up with this study, and they came up with a prevalence of 30.26%. So almost a third of patients had evidence of PRISM. And this study was from Uttar Pradesh, and I'm not sure how many of these were smokers and non-smokers, but you can see that almost a third of patients with a mixture of with a mixture of exposure to noxious fumes, either as smoking or indoor air pollution or outdoor air pollution, have developed features of PRISM. And that's a very, very important number to look at. And sometime in the discussion, maybe we can look at what constitutes the factors that lead to smaller airways, narrowed airways, because that's a burgeoning area coming out in the last few GOLD guidelines. Can I have the next slide, please? So if you look at what causes the variations that lead to PRISM, the epidemiological characteristic of these conditions, you can see that the various different factors. Top of the list, of course, we need to consider environmental and occupational exposures. And we know that the varying degrees of air pollution, Delhi, pretty bad. Dr. Arjun Khanna, not very far away from Delhi, may also be experiencing this. There are occupational hazards, and of course, smoking rates, which vary hugely across the country. Look at the GBD data, the global burden of disease, where we look at air pollution and we look at smoking and other determinants of airflow obstruction. The second, of course, is how often do we pick up PRISM? Because spirometry is not widely available in a country like India. Healthcare services to pick up conditions like PRISM and COPD are not widely available. So our reporting will also be very, very different across the country and across the globe. We also know, of course, that there are a lot of genetic factors. Good studies like the CAN code and the COPD gene study showed us that there are various predisposing factors. And these include not just genetic predispositions, but also demographic factors. We know the older the person, the older the age, the population age, the more likely you are to pick up both PRISM and COPD. But also levels of education influence the prevalence of COPD and PRISM in different populations. Finally, of course, study methodology is important, which is why I refer to the Bansal study. Excellent work they've done in one center, but obviously you do it across a wider population, you have a wider sample, then you may be able to pick up very, very different numbers. So we need to all those listening should probably look at this and pursue this as an area of research. Can we go on to the next slide, please? So if you look at the etiology specifically, we look at certain major risk factors, and I'll be coming to these stepwise, but top of the list, of course, would be smoking. We're not going to go into the conditions, the root of smoking. Everyone here is handling COPD. We all know the problems associated with smoking, but I'd just like to emphasize two different terms that will come up a little later, something called centrilobular emphysema and something called peribronchial emphysema. And this is obviously depending on the distribution within the secondary pulmonary lobule of where the emphysema is predominantly located. But another important area that we must look at as a risk factor is the BMI. And we know that a high BMI can lead to mechanical compression of the chest, especially the lungs. Obesity is also associated with systemic inflammation, and obesity also is associated with certain phenotypes of asthma. And this can lead, obviously, to spirometric abnormalities. On the other end of the spectrum, a low BMI can be a result of problems that lead to diminished respiratory muscle function. We know sarcopenia occurs, for example, in a variety of conditions, including COPD. But from infancy, the pre-natal stage, the fetal stage, impaired lung development is a problem. We know that nutrition plays a big role in lung development, and impaired nutrition can cause impaired lung development. Early exposure to pollutants, indoor and outdoor. And increasingly, we recognize that exposure of the pregnant mother to pollutants can impair the lung development of the fetus. And finally, of course, a low BMI can also lead to an increased risk of infection. And this is throughout the life course of a person, which can also lead, therefore, to diminished lung function. Next slide, please. So we're looking at these in a little greater detail. So let's focus on environmental pollutants. Next slide, please. And the next slide. Yeah. So, no, sorry, go back to the previous one. Pollutants such as particulate matter, ozone, nitrogen oxides, and sulfur oxides are major parts of pollution. And these have increased with industrialization, urbanization, and these through oxidative stress lead to lung damage. Can we go on to the next slide? The second is, of course, age. And as I already mentioned, older individuals, greater decline in lung function, following a normal pattern in all of us, but accelerated with exposure to pollutants and so on. The next slide, please. Then we look at genetic factors, and there are certain specific genes from these studies, like the COPD gene study, that have identified some SNPs, single nucleotide polymorphism, within these particular genes, the PLECA gene and the CACNB2 gene, that are linked to an increased PRISM risk, and others like the sirtuin genes, which seem to predispose to COPD. The next slide, please. Then you have gender, and studies have demonstrated that females may be more susceptible to PRISM, just like smoking females are more susceptible to COPD than males. This should not be confused with thinking that males have less COPD or less PRISM than females. It's just we're talking about susceptibility. Next slide, please. And last of all, we looked at education levels, and clearly those with, next slide, please, with less education have higher PRISM prevalence. And this may be linked not only to socioeconomic factors, but also exposure to indoor and outdoor air pollution. Dr. Sandeep Shalvi showed this elegantly many years ago when he spoke about smoking, non-smoking COPD. And of course, health literacy plays a very big role. Next slide, please. Next slide. Yeah. So associated comorbidities exist with PRISM and pre-COPD patients. And this is very important because this is a bidirectional relationship. So we recognize four main comorbidities: cardiovascular conditions, hypertension, which predisposes to cardiovascular conditions, obviously, then diabetes, which is linked with cardiovascular conditions and often synergistically with hypertension to produce worse cardiovascular disease, and obesity, which is closely linked with diabetes. And as all pulmonologists will realize, one of our main areas of interest, obstructive sleep apnea, sleep disordered breathing in general, is associated with all these comorbidities. And therefore, we need to keep an eye open in our patients with COPD to pick up not only these comorbidities, but also COPD and PRISM, because we know that this group will have a faster progression to disease and greater morbidity and mortality due to both their respiratory and cardiovascular conditions. So I'm not going to go into details of this for lack of time, but we know that whenever you have these conditions, you will have worsening lung function. For instance, left ventricular dysfunction by increasing pulmonary interstitial edema, by diastolic dysfunction, and consequently pulmonary arterial pressure leading to pulmonary hypertension will affect lung function. And then those who have a higher genetic susceptibility will have a greater rapid decline in these functions. So I'm not going to go into details because we've already discussed most of this. Next slide, please. One of the challenges, some of the challenges in recognizing and diagnosing PRISM is that there's a huge clinical heterogeneity in this condition. Patients with PRISM or persons with PRISM have diverse clinical features, which makes the diagnosis more difficult to make. And most of our studies of COPD have left out patients with PRISM because the entry criterion, the most basic entry criterion, is do they have COPD defined by an FEV1 FVC ratio of less than 0.7. So clearly, these patients have been left out. Then you look at their classification. Very often, patients are misclassified. So one of the studies showed that approximately 7% of patients with PRISM have been misclassified as COPD. So we're not able to follow them up properly. And on the other end, patients who have early symptoms, which are mild, these are often overlooked and they can often be mistaken for other respiratory conditions. We already spoke about limited routine testing, and most patients have their lung function tests done only when they are symptomatic. I had to fight in my own hospital to get spirometry included as part of the routine health checkup. And I was telling them why it is more important to do lung function testing than a lot of the other blood tests that have really no role. Finally, there are diagnostic ambiguities. Dr. Arjun Khanna will be taking through some of the ways in which we make better diagnoses of all these conditions. But we look at specific lung function parameters, and we know that there is an overlap between lung function disease abnormalities and between in COPD and various other conditions. We also know that spirometry is so difficult to do. It's a very dependent procedure on the patient's cooperation, understanding, and ability to carry it through. So defining it only on lung function parameters, probably we're going to miss out some cases. So these are some of the challenges in making a diagnosis of PRISM. Next slide, please. When you look at PRISM, I said that almost a third of patients within the next 4 to 5 years go on to develop COPD. So let's examine this association a little further. Next slide, please. So if you look at the left hand, the graph, the Kaplan-Meier curve, this looks at the probability of survival depicted on the y-axis and the time extending over 10 years on the x-axis. The bottommost solid orange line is those with normal spirometry. And if you look at the other, other two lines, you have those with COPD, which is the third line, and the top you have PRISM, which is the topmost line. And you'd see that patients with with normal spirometry, the topmost line have the best outcomes. The bottommost line are those with COPD who have the worst outcomes. But you can see that the probability of survival in patients with PRISM is often as bad as those with COPD. After about 5 to 6 years, COPD patients have a greater decline. But patients with PRISM, almost for the first 5 years, have an identical mortality rate as compared to those with COPD, and much lower than those with normal spirometry. So clearly, mortality is worse in patients with PRISM than those who have a normal spirometry. Unadjusted mortality rates, which is what is depicted, are almost identical with those of COPD. And mortality within the first year was highest in PRISM. And what this may indicate is the cause of death very often was cardiovascular disease rather than lung function problems. And this we learned almost 20 years ago when the TORCH trial came out and the UPLIFT trial came out, that more than a quarter of patients died of cardiovascular disease rather than respiratory disease. And then when you re-examine these patients over time, over the next 5 years after the first 5 that I spoke about earlier, almost half had progressed to COPD. So that is why there is a good close relationship between PRISM, COPD, and mortality from these conditions, both COPD and cardiovascular disease. Next slide, please. If you also look at the Rotterdam study that was published just about 3 or 4 years ago, I think in 2020, yeah, it was 2020. This was a population-based prospective cohort. Again, you saw these groups, and here they divided COPD into GOLD 1 and GOLD 2 to 4. And you can see that, the probability of survival, very similar or identical X and Y axes. You can see those with normal spirometry had the best survival curves. Those with PRISM had the worst survival curves. And those with COPD GOLD 2 to 4 obviously had the worst survival of all. But notice that patients with PRISM actually had worse survival than those with COPD GOLD 1. And one of the reasons may be that patients with COPD GOLD 1 actually have a diagnosis of COPD made and are treated, while patients with PRISM are probably ignored. And you can see in the right-hand column, you can see that those with PRISM had a hazard ratio of 1.6, very similar to those with GOLD 2 to 4. And therefore, we think that PRISM and COPD GOLD 2 to 4 are significant predictors of all-cause mortality. Notice that these were spirometric GOLD 2 to 4, and we're not looking at the combined assessment, the A, B, and E criteria that we use now. And I think we'll get even greater relationships if we look at, GOLD 2 to, rather than GOLD 2 to 4, we look at COPD E group, which have very high mortalities. Next slide, please. Specifically looking at cardiovascular mortality, we are looking at a further great risk, relative risk of cardiovascular mortality. The adjusted hazard ratio almost touching 14 times of those with normal spirometry. So huge problems in patients with PRISM. And this is often due to cardiovascular mortality. So we should take this as PRISM as not just an indicator of COPD in the future, lung problems in the future, but also of cardiovascular disease in the future. And this is nothing new. We know from the Framingham cohort that happened a long, long time ago, FEV1, low FEV1 is a greater predictor of cardiovascular disease and stroke than cholesterol was. And yet, for the last 50 years, we've been focusing on lipid profiles rather than getting lung functions done. Next slide, please. If you look at small airways disease, and I mentioned this, those with airway diameter less than 2 millimeters of mercury, the terminal bronchioles, PRISM had higher odds and more severity when you found small airways disease in them, with more than 2.89, almost 2.9 times the odds ratio as compared with healthy controls. And you can see this is widely to the right in this forest plot. COPD has the highest chance of having small airways disease, but PRISM also has a very high rate of having small airways disease. And this, unsurprisingly, because of air trapping, is associated with the lower total lung capacity compared with healthy controls. Next slide, please. Remember, this was picked up on impulse oscillometry, and I think Dr. Khanna is going to be taking us through this. Again, when you look at other problems, exacerbations, hospitalization, those with pre-COPD and PRISM patients, pre-COPD and PRISM had a lower risk of future exacerbations than compared to COPD. But patients with PRISM, unlike patients with pre-COPD, had almost identical hospitalization risk as compared to COPD. Pre-COPD was lower. COPD and PRISM were almost identical in exacerbation rates. Next slide, please. And hospitalization risk. So you look at the prevalence of comorbidities in these patients with pre-COPD and PRISM, more obesity, more cardiovascular disease, and more diabetes. I'm just taking you through the last one because we've already spoken about cardiovascular disease. Diabetes prevalence in COPD was 9%, in PRISM was actually 17%, and in pre-COPD was 11%. Very strangely, patients with COPD, which we know to be a risk factor for association with diabetes, it was even higher in pre-COPD and PRISM, and I'm not very sure of why this has happened. I think we are still in an early stage of picking up these diseases. But one of my postgraduates many, many years ago looked at lung function and diabetics, and we were able to show that they had significant amount of restrictive lung disease, possibly because there was increased glycation of the proteins within the lung. Next slide, please. So how do we make a diagnosis? How do we prevent and treat PRISM and pre-COPD? Next slide, please. So if you look at radiological diagnosis of PRISM, in very early stages of COPD, CT scans seem to be more sensitive than the traditional lung function tests. And what they've used two different kinds of scores. One of them was using a visual CT score. And they basically use some of the terms that I spoke about earlier, centrilobular emphysema and peribronchial emphysema. And what they showed was whenever you had a decreased FVC by TLC ratio or a decreased FEV1 by TLC ratio, there was indications of gas trapping, which can predict symptom exacerbation and progression in smokers with PRISM. And this was largely looked at mainly in smokers. Pushing to the last lines, patients with PRISM have a higher prevalence of peribronchial emphysema compared to those with normal lung function. And smokers with PRISM have both the peribronchial emphysema and centrilobular emphysema compared to non-smokers with PRISM. So centrilobular emphysema, not surprising, correlates with gas trapping more than those with peribronchial emphysema. So centrilobular probably leads to more small airways obstruction. But one of the important studies, outcomes of the study was they showed that visual CT is very effective in identifying high-risk individuals with centrilobular emphysema. Next slide, please. So how do we diagnose pre-COPD? So we know that one of the big risk factors for pre-COPD is allergic bronchopulmonary aspergillosis. They have an accelerated FEV1 decline. They have a low FEF 25 to 75 when you're trying to look at small airways disease in patients with spirometry, which we know is not that sensitive or specific. You can look at airway hyperresponsiveness, which is present in very few centers. If you do a body plethysmography, you can pick up a high RV by TLC ratio, indicating air trapping, among other things. One of the most useful is CPET, but there are very few centers with CPET and even fewer pulmonologists who can accurately interpret CPET. DLCO is reduced, but again, there's very very few places with diffusion studies. Lung clearance index has been shown to have a very high predictive value, but again, is not present in many centers. It depends on, putting in inhaling radioactive material and trying to see how much gets washed out in 40 breaths. So not very easy to do. And what we do is we are more and more using impulse oscillometry or impedance oscillometry and other impedance electrographic studies, which are not widely available. Imaging studies are more widely available. This is chest CT. There is what is called parametric response mapping, which looks at something called the chances of having a parametric response PRM15. They're also using MRI using a polarized gas, hyperpolarized MRI, and of course, gadolinium enhanced MRI. But all these are not easy to do and not easy to interpret. So we're largely depending these days more and more on impulse oscillometry or impedance oscillometry. Next slide, please. And of course, CT scans. Treatment, we have no established guidelines for the diagnostic evaluation, let alone the management of PRISM. We don't have pharmacological interventions in pre-COPD. But these are extremely important to do for the simple reason that Unfortunately, pulmonologists are way behind cardiologists. And cardiologists almost 20 to 25 years ago started talking about pre-hypertension. Diabetologists started talking many years ago about pre-diabetes. And this was very important. And of course, ophthalmologists started looking at the eye and trying to pick up when a patient is in a stage of pre-proliferative diabetic retinopathy, so they could intervene before loss of vision. We are following in their footsteps by talking about pre-COPD. And I remember this topic came up almost about 15 years ago among pulmonologists also. I remember an excellent editorial by Klaus Rabe and Lauren Fabry. But we haven't had too much progress until the last few years. But what are the things we can think of? We can think of bronchodilators. We can think of anti-inflammatory drugs, and there's no evidence for these. We can think of pulmonary rehabilitation, which is always useful, but I can't see too many people attending pulmonary rehabilitation unless they become symptomatic, which is not very common in patients with pre-COPD yet, except for a small group who have early symptoms of cough and sputum, which are often ignored, but they will certainly impact overall health of the person. And of course, nutritional support, which is a whole new area. And we need to not only provide necessary dietary support, but investigate the role of antioxidants. But we are still in a very early stage, and it's much too early to be talking about immunosuppressants as the most extreme form of an anti-inflammatory drug. Next slide, please. So we're really talking about prevention, because prevention, changes in lifestyle, and managing these problems is probably where we can intervene, even without evidence, because we know that it has an overall impact on the health of the patient overall, including the very important area of cardiovascular disease, which, as we've just said, is associated with PRISM, a much higher rate of cardiovascular disease and mortality. So smoking cessation, and not just smoking cessation, but also avoidance of other risk factors, including indoor and outdoor pollution, and specifically occupational exposure. Obviously, we must emphasize regular checkups, and not only emphasize the importance of regular checkups, but make sure that these checks include either spirometry or impulse oscillometry, apart from questionnaires. Obviously, physical exercise of the whole body, but also including lung exercise will probably help. And of course, influenza and pneumococcal vaccination, that's a typo, it shouldn't be, or it should be pneumococcal vaccination in high-risk groups, but also be recognizing in patients with COPD, and maybe we can transpose the same to pre-COPD and PRISM, the role of Tdap vaccine, and in the older age group, Shingrix vaccine. And of course, when we are able to get new COVID vaccines, the role of COVID vaccine may be extremely important. So vaccination, smoking and other pollutant exposure reduction, regular checkups, and physical exercise are all we can offer the patient right now. Next slide, please. So the key takeaways: PRISM affects about 15% of the global population, but is often misdiagnosed due to delayed lung function testing. PRISM can be perceived as a transitional state to COPD, but also can be considered as a subtype that is prone to developing COPD or experiencing acute exacerbations. And both PRISM and COPD, and I'll emphasize PRISM, is associated with high all-cause mortality, and more specifically cardiovascular mortality, and is seen as a potential precursor to COPD, and therefore enhancing early detection through regular lung function screening, and of course, raising awareness, as this webinar is hopefully doing. And thanks to Dr. Salvi, Dr. Dar, Dr. Amita, and of course, GSK for trying to increase awareness of this condition. Hopefully, we can improve patient outcomes by recognizing and managing this early. Thank you so much. I'll hand it back to Dr. Amita.
Thank you, Dr. Murli. This was a fabulous talk, extremely informative, really state-of-the-art, very, very crisp, and really extremely enlightening. We got to know so much about PRISM that we really need to know. And this is basically definitely going to change completely the approach and outlook of all of us to PRISM, because we keep on coming across these CFTs, but we often don't do much. So I think this was something that we really need to know, we need to work on. And I genuinely feel that it would be great if we do if we do a trial involving multiple centers, because I just feel that the trials that have been published, they've given treatment to PRISM only for 3 months. And at the end of 3 months, they've said it's not improving, so you don't do anything. But I think probably if we treat over 6 months to 1 year, and if we have larger data, then I basically feel, according to me, we must treat PRISM, and because it is going to be, addressing the problem before it becomes a problem. And I think it'll really change the outcomes, not only pulmonary, but even cardiac. So thank you so much. This was an extremely informative talk. Fantastic. So after this, I'd like to now invite our young, dynamic, brilliant, awesome speaker, Dr. Arjun Khanna, who again requires absolutely no introduction. We have been very, very lucky that we've had fabulous speakers this time. Team GSK, can we please have Dr. Arjun's slide? Great. So as we know, Dr. Arjun, he looks very young. He is young, but he's a great achiever, extremely brilliant, very enthusiastic, always charged up. You look at him and you feel, wow, I need to do something. So a fantastic pulmonologist. He heads the pulmonary medicine at Amrita Hospital, Faridabad. He got the award of the Global Rising Star in Pulmonary Medicine at the International Workshop on Lung Health in Nice, France. So not only Indian, he impressed everybody across the world. Also in the south of France, Nice. And he's an avid researcher with over 100 publications and book chapters. And he's been invited as faculty at various national and international conferences and workshops, and has taken more than 500 invited lectures. We at Indian Chess Society keep on inviting Dr. Arjun Khanna over and over, again and again, for every program of ours, because he does complete justice and he makes us feel so good when he comes and addresses our audience. His areas of interest include advanced respiratory failure, severe COPD, difficult to treat bronchial asthma, ILD, pulmonary rehabilitation. He's the master of all. He serves in the editorial board of various national and international journals. And I must basically appreciate that for Lung India, every time we send an article to Dr. Arjun Khanna, he makes it a point that within 2 to 3 days, he will give his reply back, and he'll review it so much in detail, which I feel is wonderful, because we know how busy he is and we know how involved he is with so many other academic activities. But despite that, to actually give the review article back with wonderful suggestions, I think just shows his commitment to academics. So here we have Dr. Arjun Khanna, a brilliant, dynamic, fantastic pulmonologist and a great speaker and a wonderful friend of mine. Over to you, Arjun.
All right. Thank you so much, ma'am. I hope my wife was here and, she heard so many good things about me, because I think wives need to hear that more about their husbands. So thank you so much, ma'am, for that very kind introduction. And, ma'am, you need to stop sharing so that can the team stop sharing this so that I can share my presentation? Yeah. So thank you, ICS, Amita ma'am, for having me here today. And I have, sir has already talked about PRISM and pre-COPD. And we all know that, COPD is a diagnosis which is made by spirometry. And what's the biggest problem with diagnosis of COPD with spirometry is that when you look at just one criteria or one definition for a disease like spirometry, and you're stuck up to this, definition, which is based on spirometry with your FEV1 to FVC ratios, the biggest problem is you diagnose it too late. COPD is a disease which is not just limited to the larger airways. It is something that affects the smaller airways, the bronchioles, the parenchyma of the lung, and no compartment of the lung is left behind. And by the time, you are fixated to that beautiful value of FEV1 to FVC ratio of 0.7, the ratio being less than 7, you've lost a lot of lung function. So is there anything that can pick up COPD early? Is iOS the tool which can do that? So my talk here is in 2 parts. The first is the very basic interpretation of iOS, and then we look at some data whether or not iOS can be used to define COPD early. So, as I said, first we'll try to understand the principle of impulse oscillometry, and then we'll see if we can do something with iOS and COPD diagnosis and management, and then we'll see where COPD and where iOS fits in today in our clinical practice. So the first part of it is very, very simply the principle and technique of oscillometry. Now, we all know that in today's era, everything depends on numbers. Patients want numbers, and our treatment is dependent on numbers. And every time you start treating a patient with COPD, you need a number to treat because that's how your gold diagram works. You need an FEV1 value. That's the first thing you need to do. So lung function or a classical spirometry is considered as the gold standard for assessing airflow limitation. And we all know that COPD cannot be defined without this gold standard. You need a spirometric value to define this. However, we all know the classical limitations of spirometry. It is rigorous. It is a forceful breathing maneuver. Can be difficult for the elderly, for very small children, for people who are not, doing well. The biggest problem I believe in the diagnosis of COPD and spirometry is that it is relatively insensitive to early disease, and subtle changes in lung function would be missed out. You would see someone, this classical PRISM that we've been talking about. You would see someone who has an abnormality on the CT scan. There's an emphysema on the CT scan. The patient is symptomatic. Yet when you do their spirometry, the FEV1 to FVC ratio is not less than 0.7. And it is the spirometry is not going to tell you which compartment of the lung is specifically involved. It has not been able to do justice, especially with small airways. So, we've looked at FEV 25, 75 and all that, but we know the data is not all that convincing. So we don't really have, parameters in spirometry which tell us about the function of these smaller airways. So what is this impulse oscillometry? Impulse oscillometry A is not new. It has been around since 1950s. Unfortunately, there are too many parameters that have been tried to study in this, and that I think has made life more complicated. If we try to keep things simple, life would be much easier. And what is spirometry? Spirometry is a non-invasive technique, which is basically looking at the mechanical properties of the respiratory system. And how is it doing that? You give a sound wave to the respiratory system. The way the sound wave interacts with the respiratory system, with the dynamics, with the mechanical properties of the respiratory system, how much resistance that sound wave will get, how much, kind of the stiffness is there inside the lung, and how much of the sound wave would be absorbed, how much of the sound wave would be reflected back, is the very simple basis of an impulse oscillometry. The beauty is that it is a relatively easy test to perform. You rarely require no effort. The patients are breathing at tidal volumes. Can be done in children, can be done for very elderly, can be done for patients, who can't do a spirometry, where you are scared. There are patients who are so fragile where you can't really do a spirometry. It has a more scientifically sounder basis than our spirometry. And the biggest beauty is that it is going to talk about different compartments of the lung. It is going to talk about the inhomogeneity in the lung. It is going to talk about the smaller airways, the larger airways. And, the best part is that it's tidal breathing. So patients, when they come to us, they're apprehensive, patients are scared, they're anxious. And when you task them to do something as difficult as a forced maneuver, many times patients are not able to do it. So I think the biggest advantage of doing a spirometry or iOS over a spirometry is the ease of doing the test. And a lot of patients would be able to do it very well. So, as I said, spirometry, this oscillometry has been there since 1956. FOT or forced oscillometry was the first kind of, this kind of a challenge test in which different kind of frequencies were given to the lung. And the way those frequencies would interact with different compartments of the lung was what was studied first with FOT. Over 20 years, the animal studies got converted into human studies. Eventually, 1975, the first kind of an impulse oscillometer was developed. So it has been around for the past almost 8 decades now. They're still trying to streamline it because, as I said before, there are too many methods, there are too many parameters that they've tried to study, and I think that complicates a lot of issues. And when I try to interpret an iOS in my clinical practice, I think that is the most important thing that I also try to do. And that is what I tell my residents, that we need to keep it very basic because a lot of these parameters are still not validated. you put in half an hour of trying to understand a very complicated concept, and then at the end of the article they would tell you that this is still not validated. So I think we need to keep it very, very simple. So when you look at the way an oscillometer works, what this diagram is trying to tell you is it's actually very, very simple. There's a loudspeaker which is going to emit the sound waves. Obviously, there has to be a pneumotachograph like a spirometer, which is going to interact, which is going to pick up what is happening inside the lung of the patient. And then these sound waves are, kind of reflected to the airways. And what happens to the airways, what happens to the sound in the airways and the parenchyma of the lung is what we study. So eventually, initially when this procedure was launched, they would send multiple sound frequencies at one time. Now, most of the machines would kind of simply send one kind of a sound frequency and try to see what is happening to that single sound frequency. However, if you look at the difference between FOT and iOS, the principle more or less remains the same. In one, you send one frequency of sound waves, in the other, you send multiple frequencies, and that's about it. But the overall crux, overall matter remains similar, whether you're doing one technique or the other. This is the very basic. I know it looks terrible, this slide, but what this slide is trying to tell you is, this is the slide which is the basis of interpreting an impulse oscillometry, and I always try to show it to my residents because let's not make it complicated. So what happens is, the word that iOS measures when a sound wave is introduced to the lung, to the respiratory system, overall, whatever happens to the sound wave, some part of it is going to be absorbed, some part of it is going to be reflected back. Whatever happens to it in toto is known as the impedance or the respiratory impedance. Whenever a sound wave goes inside the lungs, in the airways, it is going to, encounter some kind of a resistance. This resistance would be there in the larger airways. This resistance would be there in the smaller airways. And this part is the resistance, which is the sound wave which is going in. There is some trouble in the airway, whether the larger airway or the smaller airway, and this is not letting the sound wave pass through it. Once the sound wave has passed through the airways, it has gone down to the parenchyma, to the smaller airways, the sound wave has gone to the chest wall, to the pleura, to the periphery of the lung. Some part of it is going to be the reflected back. Whatever part of the sound wave is reflected back is known as the reactance. This reactance is again divided into two parts. One is the capacitance and the other is the inertance. Capacitance is the simple capacitance, the respiratory physiology that we read when we are talking about the pathophysiology of other diseases, when we are talking about, this is the normal capacitance, not different as in normal physiology. And inertance is the thick part of the lung, which is going to actually absorb the sound wave and not let it reflect back. So to keep it very simple, when a sound wave is introduced to the airways, to the lung, some part of it is going to encounter some kind of resistance. Some of it is going to be absorbed in the lungs. First part is the resistance and the second part is the reactance. So the golden rule whenever an iOS report is handed over to you is to keep it simple. I always tell everyone, my residents, that when you see a spirometry report, 99% of our spirometry report is based on FEV1, FVC, and ratio of the FEV1 to FVC. Yet, the report is going to give you 20 different parameters. We don't actually rely on all those parameters because we know they are not clinically all that useful. Same is the role with impulse oscillometry. Impulse oscillometry, look at the most basic values. For whatever we know, 90% of the validated data with iOS is based on the resistance pattern, which is actually very, very simple to interpret. The more complicated part is the reactance part, wherein you look at the capacitance, the elastance, and all those complicated values. But the best part is that when you look at the data, most of these reactance parameters are not really relevant to clinical practice. When you try to study iOS, 90% of your time would be spent in understanding this 10% clinical relevance. So if you are a beginner, and if you are like me with a very limited IQ, you need to actually look at the resistant part of the iOS, because this is what is going to be more important. And this is something which is actually clinically proven is of good use. So the first step is look at the coherence. Whenever you look at a spirometry, there are certain ATS criteria which you look at. There has to be an appropriate curve. The patient has to do a spirometry well. The curves have to look good. There should be no cough, and then so on and so forth. Similarly, when you start reading an iOS report, the table there is going to give you certain values, and you need to look at where coherence is written. So coherence is the quality parameter, and very often you would see iOS which has not been done properly. The patient coughed during the maneuver. The patient had not held his cheeks properly. So you'll see a lot of times the coherence is not normal. What is the standard coherence value? The coherence value at 5 Hertz should be more than 0.8, and at 20 Hertz should be more than 0.9. And this would be there in the report. So if the coherence value is not correct, please don't interpret that iOS. The iOS needs to be repeated. So coherence is the first step that you need to report. No rocket science in this. Don't complicate it. There is going to be a chart. In the chart, there is going to be a value of coherence. If the coherence at 5 Hertz is more than 0.8, if at 20 Hertz is more than 0.9, you are good to read the iOS. So the first step is look at the coherence. The second step, obviously, as I told you, is the resistance. And we all know resistance is the most important part. And the resistance to a sound wave can be either encountered in the larger airways or in the smaller airways. Now, if you look at the normal airway, which is shown in red, a sound wave, whatever frequency of the sound wave is passed through the airways, if there is no resistance in the airways, you will see a flat graph. You will see that irrespective of the frequency of the sound wave that is passed, there would be no difference in the deflection of the sound waves. However, if you look at the resistant airway, if you see if there is resistance inside the airways, if the larger airways are blocked or if the smaller airways are blocked, the way the sound waves are going to be resisted is going to be different at different frequencies. So, larger airways, you would see in a large airway obstruction that the resistance is increased and is increased for 20 Hertz, frequencies. Whereas when smaller airways are involved, the resistance which is increased, when the total lung or the total respiratory system resistance is increased, the parameter which is studied in the iOS is known as R5 or the frequency at 5 Hertz. So if the total airway resistance is increased, the R5 is increased. If the larger airway resistance is increased, the R20 is increased. And if you are looking at the smaller airways is the total resistance minus the large airways, which means R5 minus R20. So this is something that you need to remember. R5 is increased in both large airways and small airway obstruction. R20 is increased in large or central airway obstruction. And R5 minus R20 is increased in small airway obstruction. Moving ahead. The more complicated part of it, which is known as the reactance and which is known as the resonant frequency. Now, let us very briefly talk about this reactance. The reactance talks about the elastic properties and the compliance of the lungs. And this is actually, an imaginary term or an imaginary component of impedance, which is basically trying to define what is happening to the sound wave in the smaller airways, in the parenchyma, in the interstitium, in the chest wall, because some amount of waves, the sound waves are going to be absorbed and some amount of the waves are going to be reflected back. So what you need to understand is, if the overall reactance is increased, it is becoming more negative. Something is wrong in the parenchyma, the smaller airways, the chest wall, or the area of the lung, which is distal to the large or the semi-large airways. So you would see in diseases like interstitial lung diseases, in diseases where a lot of small airways are involved, in diseases where the lung parenchyma is involved, there would be more changes with the reactance. And how do we interpret this? So whenever an iOS report is given to you, please do not look at too many values. 90% of it is going to be given to you by your resistance. In a peripheral obstruction, as I told you, the smaller airways are involved. So in smaller airways, the R5 is going to be reached, whereas the R20, which is sometimes also known as R19/20, is going to be normal. In children less than 5 years of age, we don't talk about R5, we talk about R7. Unfortunately, there is no Indian data on R7. So in India, we use R5 for children as well. So let's first try to interpret the resistance part of this graph. In peripheral obstruction or small airway obstruction, the R5 is going to be high, the R20 is going to be normal. In central airway obstruction, the R5 may be high, the R20 is going to be high, the R5 minus R20, which is the small airway obstruction, is going to be normal, which is going to be high in the small airway obstruction. When the R5, which is the combined airway disease, combined airway increase, resistance is increased, R5 is going to be high, R20 is going to be high, and R5 minus R20, all three are going to be high. On the other hand, if it is a restrictive lung disease, which is limited only to the parenchyma, which is actually very, very rare, because whatever disease it is, if it is a restrictive lung disease also, if it is an interstitial lung disease also, it is going to creep up on the smaller airways eventually as the disease becomes more severe. However, in early forms of interstitial lung disease, R5, R20 and R5 minus R20 all are going to be normal. Then let's look at the compliance data. The most important compliance data that you need to look at is X5. As I told you, the compliance of the lung is studied in the areas which are distal to the semi-large airways. Now, what is distal to the semi-large airways? The semi-large airways, or the smaller airways, what is distal to them would be the very small airways, the actual small airways, the parenchyma of the lung, the interstitium of the lung, the chest wall, the pleura. So if anything is wrong distal to the semi-small airways, the X5 is going to become more negative. In a central airway obstruction, the R20 is going to be high, but the X5 on the graph is going to be normal. If it is a combined airway obstruction means both large and small airways are involved. So if smaller airways up to the periphery of the lungs are involved, the X5 is going to become more negative. In restrictive lung disease, where the compliance of the lung is involved, the X5 is going to become more negative. So X5, don't lose sleep over it. Don't lose sleep over the frequent, the FRES and the AX. All of them are going to signify or interpret or tell you the same thing. And unfortunately, because the area of the lung, which is represented by X5, AX and FRES, is so large, it doesn't really tell you anything clinically. Because this area can be involved by the smaller airways, this area can be involved by the pleura, this area can be involved in chest wall disorders, this area can be involved in interstitial lung disease. And this is the part which is actually most difficult to understand. So don't lose sleep over it. If your X5 is becoming more negative, if your AX, which is the other way of looking at the X5, is becoming higher, this is just going to tell you that the periphery of the lung is involved with some kind of a disease, whether it is in the smaller airways, whether it is emphysema, whether it is an interstitial lung disease, whether this is a pleural thickening, you're not going to get that through this. So this is at best an indicator that something wrong is happening to the distal to the semi-large airways, which is causing some kind of a disturbance in the respiratory mechanics. So to sum it up, resistance is the most important parameter that you see. R5 is the total resistance. R20 is the large resistance. R5 minus R20 is the small airway resistance. When you look at the reactance is the compliance of the lung, is the sum total of what is happening to the sound waves once they have left the larger airways. And this can go haywire in a lot of lung disease, including interstitial lung diseases, including chest wall disorders. So we do not have a lot of clarity on how to interpret this. At best, if your reactance becomes negative, if your AX values go high, you can just say that some kind of a peripheral lung disease is there, which is not involving your central airways. There are certain standard values which you need to remember. There's a lot of debate whether, we need to have Indian standard values, whether we need to have Indian data regarding this, just like in spirometry, we have our Indian set of values. So there's a lot of debate which goes on whether, and Dr. Salvi's group has time and again shown us that there is actually no need to calculate these values. Whatever we have are good enough. So, there are certain set values when you look at your iOS, whatever machine you are using, whatever kind of a device that you have, please look at the standard values that are given there. If you can't remember those values, just look at them every time. And if the resistance or whatever you are looking at is higher than normal, then of course it is high. There are certain very complicated formulas which have been used to derive these values. I don't understand anything about them. However, what I do want you to understand and stress upon is the reversibility. Just like we do spirometry and we talk about reversibility in this, we also talk about reversibility in iOS, and this is something which is very, very important. Cutoffs are not really very well defined in children, wherein actually you use iOS more in children. But what is said is that if there is a fall in the R5 by more than 40%, then the smaller airways or the total airways are bronchodilator sensitive. The dose of salbutamol that you're going to use is the same as that you would use in a normal spirometry. If your X5, which is the reactance, if it becomes positive by 50%, then the airways are said to be, bronchodilator sensitive. And if your AX falls down by 80% after giving a bronchodilator, then your airways are bronchodilator sensitive. So 40, 50, 80, 40 in R5, 50 in X5 and 80 in AX. And look at, what I'm trying to tell you again and again. We tend to, kind of compartmentalize when we are looking at an iOS value, and we are stuck up with this, that this is for the airways, this is for the parenchyma, this is for the peripheral, lung. But you'll see that the whole lung works in toto. In human body, there are no watertight compartments. There is no ILD, there are ILDs in the early stage, which will only cause a restrictive lung defect. But we all see in our clinical practice that when the interstitial lung disease spreads onto the airways, it also causes an obstructive lung disease. So in the human body, there are no watertight compartments, and you will see reversibility being demonstrated in criteria such as X5 and AX, which classically are not supposed to look at the airways of the lung. So herein lies the problem with this modality, that it has not been crystallized as yet, and we are still trying to understand it, and it is work under progress. But bronchodilator reversibility, you need to understand these three values: 40 in R5, 50 in X5, and 80 in AX. So how do you do it? It depends on what machine you have. I have the thoracic system. So obviously you need to calibrate it. You need to run it. Your technicians know how to do it. You need to stop the bronchodilators as you do it before every spirometry maneuver. You need to tell the attendants what is going to happen to the patient. If you have a video, well and good. You need to have the anthropometry of the patient, because obviously you need to enter this before you need to get any kind of results. The patient sits on an examination chair. Patient sits comfortably with uncrossed legs. You sit straight. You take the mouthpiece. You make a tight lip seal, and you wear a nose clip so that air doesn't, you don't exhale air out through your nose piece. Obviously, you need to make it comfortable for the patient, and you need to ask the patient to have a relaxed, normal breathing, and you need to breathe for at least 30 seconds or 16 seconds for children less than 12 years of age, and there need to be at least 3 acceptable maneuvers. And obviously, if the patient's tongue is obstructing or if the patient is coughing, you need to discard that. And all the 3 maneuvers, you first need to check the coherence. If the coherence is normal, if the coherence is more than, the accepted criteria, then you can interpret these PFTs. And obviously, you make a note of the resistance values. If you are interested, you look at the resonant frequencies, the AX and all those values. But I think clinically, for all practical purposes, they don't give you too much. And of course, after giving them a bronchodilator, you repeat the test after 15 minutes to see whether the airways are bronchodilator sensitive or not. So spirometry is a extensive maneuver. It is a forced maneuver. It is something like a treadmill test. On a treadmill test, you expose the heart to a supranormal maneuver to see how the heart performs under stress. Similarly, when you do a spirometry, you give a supraphysiological stress to the lung and see how the lung performs. Whereas in oscillometry, you don't give a supraphysiological stress to the lung. It is a physiological test. Obviously, the parameters which are measured are different. We all know that. You do tidal breathing in an oscillometry. Patient cooperation is minimal. Can be done for children as small as 2 years of age. This is theoretical. We find it difficult to do it in children less than 5 to 6 years of age. Can be done in people who are very sick or patients who have a lot of comorbidities. It is more sensitive for picking up small airway resistance, and aerosol generation, which is now a cause of concern post-COVID, is low. And standardization. Now, this is something which is very important. Reference values, standardization of method is available for spirometry. Beautiful data exists. Oscillometry, work under progress. Work has been under progress since the last 7 or 8 decades, but hopefully we'll be there soon. What about the role of iOS in COPD? Do we have any valid data on it as of now? Now, when you talk about diagnosis of COPD and monitoring of COPD, as I told you, we rely on a very insensitive tool, which is the FEV1 to FVC ratio. So probably, as we have more data, we'll be able to diagnose COPD much more earlier based on iOS. Now, this is just a hypothesis. This has not been proven yet. However, as we collect more data, as we get to understand the iOS in more details, as we talk about more about lung resistance, and we all understand now that a lot of emphysema is actually a peripheral lung disease, probably in the years to come, we'll have more values and we would be able to diagnose COPD based on iOS. We don't do that as of now. Pediatric applications is something there we find a lot of role of iOS in our practice. Our pediatricians do send a lot of patients to us for iOS. Children less than 5 years of age, you are supposed to measure the R7 values. Unfortunately, still not available in most of the machines in India. So you do kind of rely on the R5 values. Very good data, longitudinal data coming up on, this is from the COPD gene cohort, wherein they're actually doing iOS in younger children. And they're looking at the trajectories of lung growth in children using the iOS. And I think one very good determinant, one very good use of iOS, which we do in our clinical practice, is in patients where you suspect functional breathlessness. In those patients, if you do an iOS and if all the values are absolutely normal, then you are absolutely sure that, this patient is malingering and the patient is not breathless. And of course, there is some data that is there with monitoring of various diseases, including asthma, COPD, small airway disease, you name it, and you would find a paper on it, wherein iOS has been used to monitor these diseases and the response of the bronchodilators and the outcome parameters. But these are only studies and they have not been inculcated into any of the guidelines. So this is still work under progress. But the way things are looking up, probably in the years to come, we would have a lot of data wherein diagnosis and monitoring would both be possible with, iOS. COPD, there is some data, and obviously because, as I said before, COPD is a disease of the peripheral airways. So I think it is a sensitive tool to pick up resistance in the peripheral airways. I think earlier than COPD, but that's about it. We can't diagnose COPD as of now based on an iOS. For asthma, I think the biggest utility would be picking up asthma in younger children, wherein kids are not able to do a spirometry properly. And then, of course, you can do a bronchodilator reversibility with iOS beautifully. So asthma, again, was thought to be a disease of the larger airways when we were students. Now it is very well understood that asthma very well can be a disease of the smaller airways. There are phenotypes of asthma where the smaller airways are involved actually much more than the larger airways. So both asthma and COPD, we will have more data in the times to come where it is used early in the diagnosis and management and also in the monitoring. There are certain studies, wherein they have looked at one of those studies, and this is again was quoted. This is the France study, which was quoted in Gold as well, wherein they talk very briefly about iOS, and they have quoted this study that it does correlate somehow with the spirometric values, but how we don't really know. But there is no, direct correlation between the iOS values and the FEV1 to FVC values. There is no way we can say that an FEV1 value of, say, 45% correlates with what kind of a value on a R5 or R20. But the subjective data that is there for both the modalities, it is in coherence. It is not that, if airway resistance is high in spirometry, it is going to be low in iOS. So I think whatever data we have as of now is coherent. But we still cannot say that the patient has COPD, or you can manage COPD, or you can monitor COPD based on an iOS. Future directions, I think it is a very, very good tool, provided we have more, epidemiological data and we understand how to use the more complicated parameters very well. We need further research on this. And obviously, as I always say, that any obstructive airways disease, the lung function is just one parameter. And the outcome of the patient doesn't always depend on lung functions. You can have patients with absolutely fantastic spirometries still being frequent exacerbators. And you can have patients with terrible lung functions with FEV1s of, less than 30% still doing very well on a single inhaler or no drugs at all. So I think when we talk about lung function testing, it is very good. We do need it at times to establish the diagnosis, but the overall management of the patient doesn't always depend on the lung function of the patient. So iOS is something that measures, to sum it up, it measures the airflow obstruction on a spontaneous breath. And when a sound wave is attached or given to a respiratory system, the R is the most important data that you need to look at. R5, R20, R5 minus R20 reactance, which is the X, can be affected by a trillion things. So don't lose sleep over it if you cannot understand it. As of now, it is an upcoming tool. This slide says it's an indispensable tool. No, it's not an indispensable tool. It's an upcoming tool, which is probably going to be very useful in the times to come. As of now, it's something that is there in our armamentarium. We do use it sometimes. Where exactly, I really don't know. I think the biggest advantage, as I said before, is sicker patients, younger children, and wherein you are absolutely hell-bent on proving there is small airways resistance. And, this is a debate always, that even if you show that there is small airway resistance, would your management change in any way at all? Would your extra fine beclomethasone and those things, there is very good data now to show that it doesn't really work. It is more of a gimmick. So where exactly to use it in clinical practice is work under progress, but it is a good tool. It is something that you need to know for your final exams, and hopefully in the years to come, it would become more useful. So with that, I thank you for your patient hearing. I hope I have made certain things a little simpler. Yeah. So over to Amita ma'am and Dr. Yogesh.
Thank you, Arjun. Thank you so much for an exhaustive, informative, state-of-the-art, fantastic talk. This was amazing. I just feel that impulse oscillometry is proving itself to be more and more useful. And I think this was such a concise and crisp overall approach to impulse oscillometry, which I'm just so happy about. Arjun, thank you so much. I think this is a talk which is really for keeps. Thank you very, very much. So now we'll start with our panel discussion. I'm just getting a hospital call. If I can just get a minute, just a minute, please.
Sure, ma'am. Murli sir, I'll ask the first question to you.
Sure.
So I can see the question there, and Dr. Dipesh has asked, where do we, there are these patients, we were talking about how to manage these patients with PRISM. And so this is a guy who has a chronic bronchitis phenotype, who's coming to you with, we know it's chronic bronchitis, but the ratios are normal. FEV1 to FVC is normal. So how do you treat this? The Rethink trial, which was published in NEJM, which Amita ma'am was talking about, looked at the outcome of giving bronchodilators, dual LAMA-LABA to patients with so-called PRISM, wherein the ratios were normal, but the patient had chronic bronchitis. And in these patients, over 12 weeks, it was shown that it doesn't really decrease their breathlessness. And I think a very strange study to get published in NEJM. I think whatever we send, they just send our articles into trash. And then when people come up with this kind of a study wherein a patient is breathless, the patient has a COPD or a chronic bronchitis phenotype on CT scan, but the FEV1 to FVC ratio is normal. They give them bronchodilators and they tell you bronchodilators don't work. I just don't understand how to interpret this. Your take on this?
Absolutely. I mean, if you have no obstruction, you're not going to get any response from a bronchodilator, clearly. So what you need to really do is go to the underlying cause, and that's the other thing that we're talking about. How do you reduce the inflammation rather than just give them bronchodilation? And this is no new concept. one of the things I've found over the last 30 years of practicing pulmonology is all these things come back with new names. So when I started teaching my undergraduates about the stages of COPD, those were early days when people used to talk. It had changed to COPD by the time I became a pulmonologist, but earlier they used to talk about chronic bronchitis and emphysema. And in chronic bronchitis, we recognize stages of chronic non-obstructive bronchitis or chronic simple bronchitis, that is then called, which is what you're talking about when your FEV1, FVC are normal. And then you go on to the chronic obstructive bronchitis and so on. So obviously, if it's non-obstructive, there is going to be a problem with only which symptoms are not going to get corrected by a bronchodilator. So those conditions, what you probably need to use and investigate is anti-inflammatory treatments, including possibly something like N-acetylcysteine or one of the other drugs that help to reduce the mucus production. And of course, what we discussed earlier, take away the exposure to whatever is causing the problem. So, I mean, that was a ridiculous study. And as you said, studies are accepted based on where they come from rather than what they actually contain. And that's tragic, but let's hope for better times.
So ma'am is back. And the next question is, Dr. Bhavya is asking, can iOS be used to monitor response to treatment in COPD? I'll take that. No, the answer is no. As of now, it's not validated. So no, you cannot monitor any response. There is data. There are articles wherein they've used it to see the response to bronchodilators in asthma, in COPD, you name it. We did a study on this at Dr. Talwar's center where we looked at ILD and, very, very impressive study got published in the ERJ. But if you ask me how to use it clinically, I still would draw a blank. So the answer is no, not as of now.
Great. Okay, so we have more questions, but I think I'll just start with the questions that I wanted to ask, And, I'm so happy, Arjun, you asked the first question about the NEGM study. And I'm so happy that Dr. Murli was so honest in answering it. Because, even I just felt that the study was absolutely substandard. And the thing is that probably they planned the study for a shorter period. But NEGM should not have accepted the study and should have asked them to do it for a longer period. Because I just feel it's so unfair to, write off something based on a 3-month study, which is just so many patients of COPD and asthma don't respond to 3 months of treatment. Then how can PRISM be responding? So that was great. Start with the basics, So I'd like to start with Dr. Murli. So your talk was really very, very lucid and so very informative about PRISM. So I want to, for the benefit of those people who might have joined late, and also for everybody to know in the practice. So basically, what actually is the prevalence of PRISM and pre-COPD in your clinical practice? And is PRISM a precursor of COPD? And if so, what are the factors that influence progression of PRISM to COPD? So 3 questions for you.
Yeah, thank you. So I'm going to start with the last first, or the second first, and then we go on to its progression. So about 30% of patients with PRISM have been shown to go on within 4 to 5 years to develop COPD. So that's one important thing, close to a third of patients. The next is if you follow them up for even longer, almost half of them are going to develop COPD. So clearly PRISM is something that is very likely, as likely as not to progress to COPD. And possibly, because this term is relatively new, you follow them up even longer, more of them are going to develop COPD. And this is perhaps slightly different from what was called gold zero in the old days, when they did not have any airflow obstruction. And then we were never sure how many are going to progress to gold 1, 2, and 3, and so on. So that's the first part of it. The second part is, how do you prevent them from progressing? Is probably to remove whatever is causing the COPD. If it's a genetic factor, we try and intervene with the non-genetic factors that work on a person who's got a genetic predisposition. You're not going to be able to change your genes at this stage. And certainly you don't want genetic manipulation in somebody with the relatively milder stage of COPD. The third thing that I would do is perhaps, think of any predisposing factors. For example, if they have higher levels of eosinophils, I may consider starting these patients on an inhaled steroid in a low dose to see what happens with their response to treatment. Because we know that asthma is one of the precursors for COPD in a non-smoking population, especially when it's not well controlled. and in the presence of other risk factors. So you have the asthma COPD combination. Last of all, I would look at these patients very, very carefully for cardiovascular disease, because we know that PRISM predisposes to cardiovascular problems. And as many people die or more people die of cardiovascular disease in the PRISM population. So that's a group I think deserves a study for, do things like statins and beta blockers work in the PRISM population. We know that in COPD populations, there is some benefit, not in preventing acute exacerbations as the StatCope study was meant to do. But if you look at large meta-analyses, beta blockers seem to have a role, statins have a role. So that's a group I would look carefully. Do these people have any evidence of cardiovascular disease? I'd probably do an ASCVD calculator or QRIS score and see, do they have evidence of, risk for cardiovascular disease, including strokes in the future, and intervene aggressively in these patients. And Dr. Amita, I've forgotten your first question.
Now, what is the prevalence? What is the percentage of patients you see with PRISM or pre-COPD in your OPD?
Yeah, so that's as you saw in the Mura study, less than a fifth of patients actually have PRISM. But this is a group, if you look at those who are smokers and those who are non-smokers, in the West, at least, it's much higher in the smoking population. So you catch smokers who have been smoking for maybe 10 pack years and you see them, they're more likely to have PRISM. They're also more likely to have pre-COPD. In India, we don't know. We have no data.
Okay. So just generally in your OPD, would you like to just give a number or not really sure?
I think it's a surprisingly high number. So you have patients who come to you and you do a spirometric assessment. So many of them have impaired spirometry, but they have preserved ratios. And that's very, very common. I'd say probably a third of our patients who have a good spirometry.
Yeah, I would agree. Yes, I would agree. Well, Arjun, what about you? Quite a few of your patients?
Very, very significant, ma'am. I think we do encounter it very often. So it's very common.
Right. Okay. So now, Arjun, coming to you. So again, a very important question. So basically, how important is spirometry in diagnosing PRISM and COPD? And are there any diagnostic tests that can be done to use to assess these conditions?
So of course, ma'am. I think the basis of spirometry, the basis of COPD diagnosis is spirometry. You cannot diagnose COPD without spirometry. When it comes to PRISM again, the definition of PRISM is based on a spirometry. The patient has clinical symptoms, the patient has risk factors, but the FEV1 to FVC ratio is preserved. So that is what PRISM is all about. And I think the concept of PRISM was launched to kind of, there have been terms like pre-diabetes, pre-hypertension for years, but there was nothing like pre-COPD. Around 10 years back, for the first time, the Gold actually launched this and they reverted it in 1 year because they did not have any scientific data to actually, come up with this definition of pre-COPD. And ever since then, we've been struggling whether or not to come up or how to define this pre-COPD and PRISM. So there is very good data, ma'am. Now you said that what else do we have? So if you look at the cohorts from the COPD gene study, there is a COPD gene quadrangle that they have made. And in this quadrangle, there are 4 things. To diagnose pre-COPD, you need to have risk factors. You need to have a radiology, which is, either an X-ray or preferably a HRCT chest. You need to have a spirometry, and then you need to have clinical symptoms. So there are 4 domains. Out of these 4 domains, clinical, features, risk factors, spirometry, and the radiology.
Yes.
If all 4 of them are present, then obviously the patient has COPD. Based on this, they've actually, given you values, and this is actually very easy to do. You just need to go on to the COPD gene website, and there's a very nice calculator which is available over there. So for your particular patient, you can actually enter and they would tell you what percentage or what is the chance of this patient who now has so-called pre-COPD, how much of them will go on and actually develop COPD. A part of this has been validated in the Indian subcontinent as well, but we still need more data on it. However, all said and done, you do all this statistical jugglery, you go onto the website, you do this, and you tell your patient that you have fala chance of developing COPD. How do you treat them? whatever data we have is that terrible rethink study, which tells you that you cannot treat them, even despite, treating them is not going to make any difference. As you very rightly said, small study, 3 months follow-up, only looked at the breathlessness. The biggest flaw of the study was the dose of glycopyrronium that was used was half the recommended dose. So even if you diagnose pre-COPD, on one hand, you say that pre-COPD does very, they do bad, they have cardiac comorbidities, they tend to die more, they're going to develop COPD. On the other hand, you don't have any treatment options for them. So, ma'am, I think this is all work under progress. We need to personalize therapy. This is the era of personalization of therapy. If I have a patient who is symptomatic, someone who comes to my OPD with symptoms, no one is going to come to you asymptomatic in India. I think the onus is on us and we need to treat them.
Absolutely. I think very well said. I really like this last point, because the thing is that if the patient is symptomatic, then we just can't get really anal about not wanting to treat. And the worst thing is that if it progresses, then what's the big point? Patient having come to us because we said diagnose early, treat early, and over here we just want to sit. So I think it's a very, very important message that if there is PRISM, if the patient has symptoms, then you'll have to definitely treat the patient. And it'll be great if we take up a new study. So super. Thank you so much. Arjun, this was really very, very clear. So, Dr. Murli, coming back to you. So actually, you did answer, but I'm just going to ask you once again that basically, what are the pharmacological interventions are you recommending in patients with PRISM and pre-COPD? And what are the evidence-based recommendations?
Right.
Because
So
you spoke about, the beta blockers and statins and all, but that was probably for cardiovascular. So what would you recommend over here from pulmonary point of view? And any recommendations?
at the moment, we don't have any evidence-based recommendations, absolutely none. As Arjun was just saying, the concepts of PRISM and pre-COPD have been in and out of the GOLD guidelines or the GOLD document. They're not guidelines, the GOLD document. But if you look at the discussions of what they describe, the discussions have been going on for a very long time. And because of lack of evidence, they've not put it into the guideline. So now it's coming up as think about PRISM, think about pre-COPD, but we really can't use any evidence-based, guidelines or treatment based on such guidelines. So as I said earlier, I would probably use a bronchodilator to handle symptoms if the patient is symptomatic. I might use a glycopyrronium, I might use a LABA, I might use a combination of these. I would use the same criteria that we are using for COPD. If there is a eosinophil count of greater than 300, I might be tempted to start the person on ICS LABA. And if the person has a count less than 100, I definitely would not do it. So I think in between, I would be basing my treatment choices on other markers. I might do a pheno, for example, and then take a call on, is this patient likely to benefit from an inhaled steroid or not? So that would be where I am at the moment. But the most important thing, I think, in PRISM and pre-COPD, like it is with with pre-hypertension and pre-diabetes, is lifestyle changes. And that's where really this concept of pre-COPD becomes very, very important. I'd be aggressive about suggesting smoking cessation and intervening very actively and telling them, look, you've got a 1/3 chance of going on to have this horrible condition in the next 5 years, because people don't even know about COPD, let alone pre-COPD. So that's where education becomes very important, both of the patient and the doctor.
Fantastic. So probably, if the eosinophils are less than 300, we'll give probably LABA-LAMA. And otherwise, we'll give LABA ICS if the eosinophils are more than 300. So that's what we'll do. So probably the way we treat either asthma or COPD, the earlier ones, probably we treat like that. So wonderful. This was great. Arjun, there are just so many questions coming on iOS. I'll try to club a few. So Dr. Ranjit is asking, how can iOS be used to differentiate between small airway obstruction and airflow limitation caused by other factors?
So again,
So after you answer this, I'll ask you one more question because you may forget.
Sure.
Because we have just too many questions. So we'll just try to cover all of them.
Sure.
And I'm so excited that the audience has been so proactive.
Sure, ma'am.
So after you answer this, I'll ask you one more question.
So resistance, you need to look at 3 parameters. Keep it very simple. R5, total resistance is increased. R20 is the larger airways. So where are we left with? The smaller airways is R5 minus R20. As I said before, the human body does not have hard lines. These are not watertight boundaries. So there would be diseases wherein everything is increased. In COPD, asthma, large airways, small airways, everything is involved. So, we don't need to be very pragmatic about what is increased because the treatment doesn't really change. So the treatment remains same, whether it is small airways or large airways which are involved. Whatever drugs we have for so-called small airway involvement is a matter of question, and we don't really know if it does really work there, because even if you look at the extra fine beclomethasone and if you look at the lung deposition of that, it is as good as Symbicort, it is as good as nebulized drugs. So R5, R20, R5 minus R20. Just based on these parameters, for the sake of reading an iOS, you can say this is small is more predominant, or large is more predominant. If you look at treatment outcomes or treatment changes, doesn't make any difference.
Okay, great. So this was fantastic. And there is this other question that what is the optimal frequency range for iOS? Just a minute. What is the optimal frequency range for iOS measurements in COPD patients, and how does this vary with disease severity?
I'm not very sure, ma'am. I think when we are talking about COPD, I think what they want to understand is, I think with COPD, as it gets more advanced, the disease gets more peripheral, or maybe in emphysematous lungs, the disease is more peripheral. So maybe in patients with emphysema or more advanced disease, you would see changes more in the smaller airways. So in these patients, R5 is going to be increased, R5 minus R20 is going to be increased. And because the periphery of the lung is involved, the elastic structure of the lung is involved, and COPD is a disease which affects all parameters, all boundaries. It is going to affect the chest wall as well. It is going to affect the diaphragm as well. It is going to involve the periphery of the lung as well. So I think it would kind of look at, when you look at the reactance, it gets more negative, and the AX is going to get more positive. However, there are no, certain values that if the resistance is more than this, like in spirometry, if the FEV1 is less than 30%, it is very severe. If the FEV1 is less than 50%, it is severe. We do not have certain values. We do not have, same values for iOS, whether it is R5, R20, whatever it is, whether it will tell you whether this is mild, moderate, and severe. There is some data, but it is not validated. You cannot take it as the final word.
Okay, fine. So we just stick to this only.
Sorry, your voice broke up there.
Yeah, I'm sorry. Actually, yeah, just suddenly the network moved, So just a minute. Yeah. So Dr. Murli, coming to you, Dr. NK is asking, what are the factors that can influence the reproducibility and reliability of iOS measurements?
Is that to me or to Dr. Arjun?
Whoever, I think Dr. Arjun can take it, then I can come to you with a PRISM question.
Sure,
Okay,
ma'am.
I'll start off. So basically, you have to follow a very strict protocol, beautifully outlined by Dr. Arjun. Second, and this is something Dr. Sandeep Salmi was telling me just yesterday, that between instruments, there's a lot of variability. So you cannot rely on measurements done on two different companies' instruments for iOS or FOT. Within the instrument, there seems to be a fair degree of reliability as long as it's done properly. Now, one of the things we've been noticing is we've been getting a lot of problems when, for example, the nose clip is not fixed properly or it's slightly loose. So our nose clip had got a bit loose, and we were getting huge variations in the reactance curves especially, but also in the resistance curves. Thirdly, and I think this is important, if the patient breathes more actively, you get very, very different values between so for example, we've seen patients post-bronchodilator getting increased resistance, both R5 and R20. And then you look a little carefully and you see the VT, the tidal volume, is increased between the pre and the post-bronchodilator. Obviously, when you get a greater volume, you're going to get greater resistance. So that gives you an idea that the person has a paradoxical bronchospasm or a paradoxical increase in resistance. So you must look at all these factors. And one of the things that, Dr. Arjun mentioned earlier is always look at the coherence. And these days, you can also look at the Z values to compare the two. So that's very, very important that you look at the coherence and the Z values before you can interpret impulse oscillometry accurately.
Okay.
Over to you.
Same, sir, same. I think
No,
it
I
also
think this
depends
was
on the technicians. Two technicians every day whenever they're posted. So we all, it depends. It varies from technician to technician also.
I think this was fabulous. This was fantastic. So, Arjun, coming to you. So, we have Dr. Ronak asking. He's worked, he's done his DNB with us. One of the brightest students that we had, who's a great, very successful and respected consultant today. So, Dr. Ronak is asking, when you have a patient with clinical obstructive airway disease in your OPD, do you order spirometry first, then an IOS later based on spirometry, or you do both together? And do you do an iOS if the spirometry is abnormal?
All right. So I'll tell you the honest answer to that. In our hospital, one, there is something known as a complete PFT package. So a lot of patients who go to the health checkup and sometimes in the ward, we write the complete PFT package. So in that complete PFT package, patient gets a spirometry, a body box, along with an iOS. Why we do this? We get a lot of data with this, and because we are a teaching center, we generate data, and one of our residents is actually doing work on this. Uh, I would ask for an iOS in my OPD. My go-to test would be spirometry. Last 2 to 3 years, my go-to test has become body box plethysmography with bronchodilator reversibility and diffusion, because I think it gives you so much. It has just changed my practice. All these wherein you don't understand what is causing the breathlessness, you do a body box and bang, you're there, and it tells you so many things about the lung. So if I have a patient wherein I cannot really understand whether this patient has actually got true breathlessness or not, or if the patient is functional, in those patients, if the IOS is absolutely normal, there is no increase in any of the resistance value, the triangles and all, everything looks beautiful, then probably your patient is not breathless. In my clinical practice, I do it in those patients. I do it in a lot of patients who are referred from the pediatrics department, because somehow the pediatricians have become very fond of this test and they don't seem to understand how to interpret it. And then they keep coming back to you that, with this report, what am I now supposed to do with the patient? So I think this sums up the problem with iOS right now. A lot of us have it, but we don't know how to use it in the right clinical context. So Ronak, I think my answer is going to be there. It is actually a very gray zone as of now. A lot of people do it as a part of their complete PFT packages. It generates revenue, and because you've bought the machine, you need to do something with it, right? I think that's the number one reason why iOS is done. Number two would be if you have DNB, MD, DM residents, some of them would be having some kind of a thesis with it. Absolutely certain. And I think that is the another reason why I do it. Third would be to rule out functional patient. Fourth, my wife is a pediatrician and she sends me patients. So if I don't do it, I get in trouble. So these are my four reasons of doing the iOS.
I'm going to defer, Dr. Amita. I find it's very, very useful, especially when you suspect disease and the spirometry, either the patient cannot do, and a surprising number of patients are unable to do it or do it really badly, or they get easily exhausted. Then iOS is very, very useful. There are some patients, for example, you're trying to do spirometry and they cough a lot, and you don't have that problem when you do iOS. And the third group is those who've already had a spirometry outside. It looks normal, and yet you know that this patient has symptoms, risk factors, and you want to do it. Then you do an iOS and you will pick up a surprising number of small airways disease in these patients. How accurate it is, open to question at this point in time. I think we don't have enough validated studies, but again, something we know is that the cutoffs don't vary much between those of the West, where they have validated studies or some validated studies, and our population. Not much of a difference. The curves are almost exactly the same. So I do use it. I use it more and more. I use it as a complementary investigation to spirometry, and I think it works remarkably well.
Yeah, so actually, we all know that iOS is fantastic. I'm a complete iOS freak. And as Dr. Arjun said, we have two of our residents who are doing a thesis. So every person who goes, so actually these days we hardly ask for a spirometry. We always ask for a complete spirometry. I mean, a complete PFT, because the lung volume by body box and diffusion is so very important. And we are getting just so much of data with iOS. So I feel iOS is fantastic. Especially, of course, this is out of the topic, but in patients of cough variant asthma, somehow PFT always comes normal and never shows reversibility, and IOS always shows, abnormality, and it shows reversibility. And this helps because patients are then okay to take inhalers. Otherwise, they are not really happy to take inhalers. Over here, Dr. Ronak had asked a very specific question that do you do spirometry first? And after looking at the report, if it's abnormal, do you do IOS? That, or do you do both together? So we all are doing both together, I believe, but ideally, what should it be? He was asking. And if the spirometry is already abnormal, then do you need an IOS? So probably not. So I think his questions are valid. If the spirometry is abnormal, then we don't really need an IOS. Unless the patient is not ready to take the inhaler, then you just take a chance if IOS will show some reversibility. And otherwise, ideally, we should do spirometry first. And if it's abnormal, then do an IOS. But sometimes patients are not happy coming again and again. So we often do both together, and we also trying to generate data. So is that correct? Ideally, if spirometry abnormal, don't do IOS, correct?
Yeah.
Okay,
One of the
great.
biggest drawbacks of impulse oscillometry is you don't get volumes. You don't get the FVC, I mean, which I think is an important measure in many circumstances, especially when we are following up our ILDs, for example. Spirometry far, far is better than impulse oscillometry. And, as Dr. Arjun was saying, I think the body box measurements are far superior to both. So that should really be your go-to if you have one.
Yeah, absolutely. So, Dr. Murli, coming to you, we have Dr. Ajit Kulkarni from our Maharashtra, very intelligent and enthusiastic, fantastic doctor doing great work. He's asking, does PRISM need ICS as treatment of choice?
I wish I could say yes to that, because I personally believe that a small number of them will need it, but it's certainly not validated. I wouldn't even call it the treatment of choice, because if a person does not have a eosinophilic kind of inflammation underlying it, I'm not sure what it's going to do. In fact, there's a risk that you may be increasing the risk of infections and aggravating or accelerating the process of COPD. So certainly not the drug of choice. I think there's a small group in which it may have a role, and that would be decided based on pheno and eosinophils.
Yes, absolutely. Okay, so now coming to Dr. Arjun, we have Dr. Murli who's asking, another Dr. Murli is asking for PRISM. No, sorry, so I think I'll keep this for our Dr. Murli. I'll come to Arjun with another question on iOS because there are just so many. So just a minute. Okay, so Dr. Jyoti is asking, so Arjun, this is to you. So Dr. Jyoti is asking, is FOT useful in occupational lung diseases? And would it help us to rule COPD because of occupational lung diseases? And what parameters?
Again, for occupational lung diseases, this is not a validated tool. For occupational lung diseases, the validated tools are spirometry and chest X-rays. There's an ILO chest X-ray classification, which is used for lung diseases. Of course, if you pick up and if you search this on Google, and if there would be studies, but then it is not a validated tool. If you look at the Government of India toolbox, wherein patients with ILD, patients with occupational lung diseases need to be picked up, diagnosed, monitored, it's done on spirometry. Diffusion is also indicated, and a basic chest X-ray. If you have access to, then of course HRCT. Most of these occupational lung diseases, the classical pneumoconiosis, if you look at the classification, it's just based on spirometry, not even diffusion capacity. So no, as of now, it is not a part of occupational lung disease screening.
Yeah, wonderful. Right. Okay, great. So actually, it's almost 10:30. We still have many questions. I think I'll just take 3, 4. So asking Dr. Murli. So Dr. Murli is asking our Dr. Murli that for PRISM, resistance is more important or reactance?
So the diagnosis of PRISM is based purely on spirometry, so we don't have any data on iOS. But extrapolating from that, I'd say most probably at this point, you need to look at resistance more than reactance. But inevitably, you will find that the two are linked with each other. You can't have changes in resistance and have an absolutely normal reactance. Arjun, would you agree?
So this is like comparing apples to oranges.
Exactly.
You cannot do that. PRISM is a spirometric definition. This reactance resistance has got no connection with PRISM.
Correct. I'll take one more question for Dr. Murli, then I'm going to ask two to Arjun and then maybe stop. So Dr. Murli, Dr. Jyoti again is asking that how many percentage of patients improved with early pulmonary rehabilitation, pulmonary rehab early if it was started in patient, any PRISM improved? Any idea? Do we have any data?
No data at all. To persuade patients with COPD to undergo pulmonary rehabilitation itself is a huge task. So persuade somebody who's relatively asymptomatic and you say, look, I don't have any evidence of airflow obstruction, but will you please participate in this program? Honestly, not possible.
Absolutely. Okay, fine. So great. And do you want to just tell us once, Dr. Murli, the criteria on spirometry to call it PRISM? Once, if you can just tell us.
So the name itself tells you it's preserved ratio, meaning the FEV1 FVC ratio is greater than 0.7 with impaired spirometry, which means that the FEV1 is below 80%. Okay, so based purely on that, the spirometry is impaired, but the ratio is preserved. And this could be due to one of two things. Either the FEV1 is truly low, and this is therefore a very early kind of obstruction, but not yet dropping below the ratio that is the cutoff. The other could be those with restrictive lung disease, including chest wall problems, obesity, and so on, where the FVC is also low. So since the FEV1 is low, but the FVC is also low, the ratio is preserved, but these are those with restrictive disease.
Great. So the PRISM need not only be COPD, it could be asthma also.
Absolutely.
And therefore, we just need to know, like Dr. Ajit had asked us about the role of ICS. We have to take a proper history, look for IgE, eosinophils, if any atopy anywhere else, any other part of the body. And then you decide whether the PRISM is for asthma or COPD, and then decide LABA-LAMA or LABA-ICS.
Absolutely. Couldn't have put it better. Yes.
Yeah. Okay, great. So, Arjun, now a number of questions for you. One is a good one. Dr. Shehbaz is asking how useful. So, I'm going to ask you 2-3 questions one by one. So, Dr. Shehbaz is asking how useful is iOS for elderly patients, and can iOS be done in a supine or bedridden? Means patient is lying down. Can you do an iOS?
So again, very useful for the elderly, where you want some kind of an objective measure for the lung function, but the patient is not able to do a spirometry. But remember, you won't be able to diagnose COPD with this. You would be able to say that something is wrong. The resistance is high, the reactance is negative. So you'll be able to just say that, but you won't be able to diagnose a disease. For the proper FOT maneuver, the patient needs to sit up, the patient needs to have an extended neck, and the patients do need to do a proper maneuver. So no, it is not validated for patients who are absolutely moribund, patients who are lying down, and someone who's so sick, who's on the bed. Why do you need to do an iOS? It is not going to help their management in any way. If the patient is sick and breathless and lying on the bed and is supine, go ahead, nebulize them. Why do you need to give them a number? So I don't think one would ever validate that in patients who are bedridden, because it doesn't make any clinical sense to do the same.
Correct. Okay, fine.
That was
Great.
my thought also, but that's for a lot of people here who are guiding PGs, that's a very interesting thesis. Difference between iOS, supine, and sitting.
Sitting. Yeah, I think it makes sense, very interesting. So one more question to Arjun. Dr. Puranik is asking, what is the diagnostic test of COPD, and should DLCO be done? Will it give any more data or information?
Fantastic question. I absolutely love this. There is so much of data on DLCO and early diagnosis of COPD. There is so much of data which correlates COPD with outcomes in terms of mortality, in terms of exacerbations. Diffusion capacity is something which tells you about the periphery of the lung, which tells you about the alveoli, which tells you about the pulmonary vasculature. And when you look at COPD, it affects the alveoli, it also affects the pulmonary vasculature. So in patients with emphysema, in patients with COPD, the DLCO is going to go down. There is fantastic data from the COPD gene study, which tells you that DLCO falls much before, starts falling much before than your FEV1 to FVC ratio in patients who have a pure predominant emphysema. The problem why, or the reason why GOLD does not stress on DLCO as a diagnostic modality or as an initial diagnostic tool for the diagnosis of COPD is these guidelines are meant for the world. They are not just meant for Europe or for US. You need the GOLD guidelines to steer your treatment, whether you are in Indonesia or you are in Mozambique or the most, rural parts or tribal, wherever you are posted. It is expected that spirometry would be a part of your toolkit, no matter how remote or what kind of a place you are placed in. In India, we do understand that even that would be a struggle at multiple places. And that is the exact reason why diffusion capacity has not been kept as a diagnostic point for COPD. If you look at the definition for pre-COPD, there is one very good if you just go to up to date and if you just type pre-COPD, there's a beautiful chart that they've shown. Then they have given us this Dr. Bert Chelly, who's the father of COPD or the one who does the maximum work on COPD at Harvard. He's given his own definition of pre-COPD. And in this pre-COPD definition, in the spirometric criteria or in the lung function criteria, he has used three things. One is a low diffusion capacity. The other is the classical FEV1 to FVC ratio less than 0.7. The third is if you have a documented FEV1 value, and if between the first and whatever visit it is preferably 1 year apart, if the FEV1 value has fallen less than 10%, all these three can be taken as a surrogate marker of FEV1 to FVC less than 0.7. So a low diffusion or an annual decline in FEV1 more than 10% is as good as FEV1 to FVC ratio less than 0.7%. And there is data to actually support this statement. But we don't do this because diffusion capacity is not available globally.
And I can't get away from talking about my pet area. If your DLCO is much lower than you expect from the spirometry, also consider whether this patient has pulmonary hypertension.
Hypertension, absolutely, absolutely. Especially patients of ILD, I think it becomes really very, very important. Right. And one last question to Arjun. So Arjun, can you just tell us that in a patient of COPD on iOS, though you told us in your talk, I think just like I asked Dr. Murli, I think this is the best thing to end with. In iOS, in a patient of COPD, what tells you that yes, this patient might be having COPD from iOS values? When to suspect?
Sure. So COPD, the diagnosis is not going to be made by iOS. COPD is a disease which affects all compartments of the lung. Classically, it is a disease which affects the airways of the lung. So obviously, we are talking more in terms of resistance here. So if the larger airways are involved more, which means that your patient has a chronic bronchitis kind of a phenotype, probably the R20 may be raised more than R5 minus R20. If it is an emphysema predominant COPD, wherein the smaller airways are damaged more, then probably the R5 minus R20 may be raised. Obviously, the R5, which is the total resistance, is going to be raised in patients with COPD. But if you notice, before every sentence, I'm using the word probably. And I say probably because this is still work under progress. We don't really understand how to actually do this in the real sense. And this is not a part of guidelines. So COPD, like spirometry, is just a part of the jigsaw puzzle. It is not going to tell you how to manage the patient. It is not going to tell you, what to do with this patient when they come to your OPD. It is just going to tell you something about the mechanics of the lungs. It is just going to tell you that the airway resistance is increased and there is some amount of bronchoconstriction. I think that's about it.
Great. So clinical correlation is very, very important.
To that one last sentence, Dr.
Yes.
So when you are treating a patient, then you will be going not only by, your physiological parameters, you'll also be going by the symptoms and so on. So, it's important to emphasize that you may not make a diagnosis for a clinical trial of COPD, but you'll still be treating this patient as COPD, and you could base it on spirometry, iOS, typical radiology or whatever it is. So we take all that into account when we're making the diagnosis and starting treatment. But yes, you cannot make a trial diagnosis. The rheumatologists have a term for it. They call it classification criteria. If you want to enter a person into a trial, you use classification criteria. You don't need to meet the classification criteria to treat a patient.
Wonderful, wonderfully said. So before I conclude, I just want to tell the audience that, we would like to now have the post poll. So Team GSK, if you can just flash it on their screens. So we'll wait for about 10 seconds, and I'm sure that with this fascinating and fantastic information that has been given by both our fantastic speakers, Dr. Murli and Dr. Arjun, I'm sure the answers will change and the results will change. So let's just have a post poll, please. Okay, great. So thank you so much, Dr. Murli and Arjun, for this fascinating webinar. I'm extremely happy. I think I've learned just so much, and so many doubts that we always had in our mind have actually got cleared. Dr. Murli beautifully has told us
that PRISM is something which is real. We have to diagnose in time and we have to start treating it, though the guidelines don't really talk about it. And we have to, in particular, address the modifiable factors that the patient could be having. And if we fail to do this, then the patient could end up with too many complications, which are not only respiratory but also cardiovascular. And therefore, PRISM that we are seeing in 1/3 of our patients, please look for it. Please try to compartmentalize it, whether it could be because of asthma, COPD, or interstitial lung disease, and then try to treat the patient at the earliest. And please keep this patient under observation because you could be really making a difference to that person's life. So this was phenomenal, Dr. Murli, so important. And the best thing is that the myth created by NEGM study is actually busted. And therefore, we want to know that we have to be all the more proactive when we see patients of PRISM. And thank you, Arjun. I mean, you were just fascinating. You gave such clear-cut information and you covered such beautifully all the aspects of iOS for not only patients of COPD, but also for patients of OAD, whether it is the entire respiratory, if the entire airway, the large airway or the small airway, what gets affected more. But the bottom line is that a first iOS may help, but you should not be using iOS for following up treatment, following up response to treatment. Ideally, spirometry is recommended. But I just want to ask Arjun my one question that, PFT is a maneuver which is a forceful maneuver. And therefore, very often there's small airway collapse. And patients, of emphysema who have more small airway involvement, because of the collapse of small airway, the PFT might end up not looking good. The FVC might drop further. The RV might increase more. The ratio might increase more. So I personally feel that probably iOS, if it shows improvement and if the patient is better clinically, then we may take it as an improvement, although PFT is worse or equal. What do you think, Arjun?
Ma'am, I think when I treat my patients with COPD, I just don't treat them with these spirometric values. For me, it would be, probably the fifth or sixth down the rung. It would be just one of those things that you take into consideration because it is important. I think the kind of patients that we see in our OPD as at tertiary care centers are all already group, I don't call them group E, they are group Z COPD. They're not frequent exacerbators, they are super exacerbators. So I
They're
think
always exaggerating. Yeah.
So kind of patients that we see in our OPDs, I think in those patients, irrespective of whether you do a lung function or not, the story is already written on the patient's face. But I think it's the point that you said is very well taken. I think a lot of these patients, because everyone wants numbers and today's era, patients also want, numbers. So I think when you want to give them numbers, iOS is a fair enough, it's a decent enough tool. I have my reservations regarding it because I think it is quite overused, misused by people who don't understand how to use it. So it is one of those commercial tools as of now, but I think as we understand it better, we would probably place it better in that jigsaw.
Absolutely. No, very, very well said, and Arjun, I just feel that it was very, very important, very categorically and clearly you've told us the criteria based on which you diagnose abnormalities. And you've also told us based on which criteria you do not decide response to treatment or follow-up, etc. So thank you so much, to both our fantastic speakers for the brilliant information that is given by y'all. Thank you so much to our delegates for these phenomenal questions. And a huge big thank you to our academic partners.
I think we've lost Dr. Amita. Dr. Yogesh, you want to take over and close the session? Yeah, I think she's back.
You all got me back. I'm sorry. Yeah, I'm really sorry. Yeah. Okay. Yeah, so thank you so very much. I don't know when I got lost and how much people heard me, but I just want to again thank Dr. Murli and Dr. Arjun for their phenomenal information, their knowledge, and the art that they have of imparting knowledge. I think it's phenomenal. Thank you so much.
Thank you, ma'am.
Okay, good night, everybody.
Night,
We'll get the exact number, but we've got a huge number. Yeah. Okay.
Night, ma'am.
Bye. Good night.
Good night.
Right.
Good night.